Well, nothing fancy about diode, but I really like it as a tool. When nothing works, at times it really helps you to take care of your patients. So we all know diode is 810, minimally invasive alternative, which we use adjunctive to a TRAB or a GDD post that. There are two modalities commonly used. You can either have a near complete CPC with single or multiple sittings, ranging from 270 to 360 degrees, or we can try with a limited CPC with one or two quadrants less than 180 degrees. So the full version is ideal for refractory glaucomas and those which have a poor visual potential, while the limited version of this would be for more aggressive approaches where you don't want to take the risk of a wipeout, or you don't really want to take the risk of patient losing their vision. If you're planning to do a repeat CPC, a limited one would be the answer. For some post-vitrectomy patients and for patients with thin sclera or uveitic glaucoma, again, limited CPC works pretty well. You just have to be very careful with young patients because of the risk of phthisis and hypotony in them. So for me, a big no is doing a DLCP in a patient who has 60 or over pressures with no perception of light. So essentially what we really need to take care of in patients with high pressures and no perception of light is inflammation. So giving a steroid with a cycloplegic really works. We don't want to end up with sympathetic ophthalmia, so a big no for no PLIs with high pressures. Just make them comfortable. As regards the test CPC, now there are a lot of people who are coming up with an option that before you step up into a full-blown CPC of 180 degree or more, it's a good idea to try a low-risk trial with 90 degree CPC in a high-risk eye before planning a full treatment. The gospel truth is that you need to have different energy levels for different diseases and different races. What works for Indian eyes may not work for Caucasian eyes. So lower energy levels are adequate for effective TSCPC in Asian eyes. So we need to really titrate depending upon the type of glaucoma, the age of the patient, and the risk of the race of the patient. So there are two ways we titrate our treatment. One is by POP, and the other one is that we give a slow treatment in our patients. So for the low burn, low energy thing, we need to give it for a higher duration. So there are two ways to go about this. One is to give 1250 millivolts with 4.5 second duration for eyes with darker pigmentation. And we can increase the wattage with reduced duration for eyes with other colors of pigmentation. The pop titration for this, you would have to hear a micro pop that is coming out from explosion of a ciliary process, but that's not really a very great idea because it's eventually going to cause some amount of inflammation and can compromise the patient's eye. Although studies have shown equivalent outcomes, but the safety profile of the low burn group is much better. So I would always prefer going by a slow burn and not waiting for the pop to come. So avoiding a pop, avoiding micro explosions, it reduces the risk of hemorrhage and scleral damage and eventual hypotony in these patients. Appropriate probe placement and spacing is really important, either going too anterior, too posterior, or overlapping between the various spots can actually injure the non-target tissue. And so placing the probe just posterior to the limbus and avoiding treatment too near to the iris root really works. I always prefer to treat certain untreated buffer zones. That gives you a viable option to go back again in case you need be, but it gives you a good healthy outcome and the sclera also remains injury-free. Prefer to leave about 1.5 clock hours around 3 and 9 o'clock positions. Well, histological studies have shown that patients who have undergone a diode laser photocoagulation, putting your probe anterior or posterior by 0.5 millimeters also directly affects the outcome. So that's what shows that we really need to put our probe very precisely. And for doing that, it's always a good idea to use a transillumination technique. You can either do a transcorneal illumination or a transscleral illumination, whatever you are comfortable with, but it gives you a precise localization of where the ciliary body is lying. The pediatric globes are quite different from adult globes. Ciliary body in a normal child attains 3/4 of its adult size by 2 years of age, but in eyes with primary congenital glaucoma in children less than 5 years, we see that the ciliary body is relatively more posterior than in a healthy eye. So, because of this variability of the position of ciliary body, just using your probe around the limbus will not work for these patients, and therefore transillumination is really, really important. So using a simple transillumination technique by a simple pen torch can also help delineate the ciliary body shadow, and once you mark the spots where you have seen the shadow, you can safely go ahead and do an effective TSCPC. There are some studies which have shown double arc slow coagulation that works well. I've recently started using this technique wherein I know that I want to judge the response of the patient. I have tried using this double arc technique in separate quadrants in high myopes wherein there is already a compromised split fixation, and I don't want to be too aggressive in treating them. So a superior double arc or an inferior double arc itself sometimes gives a good outcome to the desired values. As regards post-op medications, I don't really stop the pre-laser anti-glaucoma medication suddenly. I prefer to give them for at least 3 weeks as they were continuing, so that by that time the effect of CPC comes and we can really maintain the pressures in a much better way. Topical steroids given at least for a month or more in a tapering dose. Cycloplegics are a must, which even if the patient has a good visual potential, it really takes care of the ciliary spasm. And when to retreat, there is no hurry in retreatment. I retreat only if I know that there is no adequate response, at least for 4 weeks. So the retreatment happens after 4 weeks. Well, we need to remember that when we are doing CPC, 2 + 2 is not equal to 4. The cumulative energy over multiple sessions really can cause hypotony and can result in the patient moving towards phthisis. Especially when repeated often in the same sectors, the complications are more. So therefore, I prefer to leave buffer zones, as I mentioned earlier, giving me a chance to go back to those areas, and I draw where I draw in the patient's file or on the patient's card wherever I have applied the spots. So my take home is to go slow, to avoid areas of scleral thinning, areas of prior glaucoma surgery, and I would always suggest using a transillumination technique for marking out the ciliary body, and especially an abnormally short, long and pediatric glaucometer size. And after each application of energy, the handpiece should move the distance of approximately 1 foot plate for adjacent subsequent applications, and I would at least wait for a month to retreat. So with good visual potential eyes also, I have a good experience using CPC when there is a risk of wipeout in those patients. So thank you.
Thank you very much, Parul. Just a quick question whilst you're there. How do you find the balance of efficacy and safety for micropulse?
I don't have micropulse, so I've never had an experience with it. Yes.
Any questions from the audience? Okay.
For any other talks too, we are open for a question or two. For me? Yeah, okay.
I totally agree about your lecture. Very nice lecture. But I am against you about the using of CPC in the uveitic glaucoma, really. Because of the uveitic glaucoma, most of cases are have an inflammatory process in the ciliary body, and it's already damaged by fibrosis, by inflammation. So CPC may induce more risk of hypotony and phthisis bulbi more than the other types of glaucoma.
Yeah, so not in active uveitis where I've tried everything else and everything else has failed. Even then with slow burn and with low settings, I've had a fairly decent result. So nothing with an active inflammation. I agree on that front. Yeah. Thank you.
Thank you very much, everyone, for the questions. If there's any further questions from any of the speakers, please take it outside. We'll have to move on to the next session now. Thank you very much for all your attention.